Hi, this is Group 18 and this is our presentation on infections of the middle ear. We've chosen to do this presentation in the form of a case study and we hope you find it informative. So a 7-year-old boy is brought to you by his mother and he is complaining of pain in his left ear. So his symptoms are a headache, fever, pain, dulled hearing and loss of taste. The fever can be explained by release of inflammatory mediators in response to infection. Loss of taste can be explained by compromisation of cauda tympani, a branch of the cranial nerve number 7, the facial nerve. The cauda tympani runs through the middle ear and it provides taste sensation to the anterior 2/3 of the tongue. So compromisation of this nerve can cause loss of taste. Dulled hearing is caused by effusion, which dampens the movements of the ossicles, leading to a conductive hearing loss, and it feels like you have water stuck in your ear. The pain is due to inflammation, which irritates the nerves, providing sensation to the middle ear. And sometimes you can get a build-up of pressure in the middle ear, which causes a build-up of pain that is released as the tympanic membrane ruptures, and you will find a green discharge as a result. So signs on examination, you can see that the tympanic membrane is inflamed and is bulging outwards. In some cases where the eustachian tube is blocked, the eardrum may be retracted completely because the atmospheric pressure is higher than that of the pressure within the middle ear. And this is due to the movement of air from the middle ear into the surrounding air cells. So causes of middle ear infections. The eustachian tube passes between the middle ear and the nasopharynx. So infections of the nose, throat and oral cavity can all migrate to the ear. So an infection from the throat, such as tonsillitis, can move into the middle ear and cause eustachian tube blockage, as can hypertrophy of the tonsils. The organisms that cause infections of the ear include Streptococcus pneumoniae, Haemophilus influenza, Group A streps, and respiratory viruses.
So, initially, for initial treatment, the majority of cases will resolve spontaneously, with patients only needing to take analgesia to treat the symptoms that they're getting. However, in mild to moderate cases, antibiotics might be needed. A mild to moderate case would be if the symptoms have lasted for more than 3 days, if they're particularly severe as well, if there's any otorrhea, which is discharge from the ear, and if any complications develop, and I'll go on to complications later. Antibiotics that are used are usually a 5-day course of amoxicillin or erythromycin if they're allergic to penicillins. So, as you can see here, on further examination of this young lad that's come in, you'd notice that the affected ear is sticking out slightly more than normal, and you can see there's inflammation behind the affected ear. Now, this was one of the pictures that we could find, but it wouldn't be as serious in our case study, and if you managed to miss that and had to have a further exam to find that, then that'd be a bit worrying. So with mastoiditis, that's what that was, by the way. It's a spread of infection from the middle ear into the mastoid antrum via the adductus, which is in the epitympanic recess. It can spread to the mastoid air cells posterior to the ear, and then from there, the infection can spread to the middle cranial fossa, and in the middle cranial fossa it can cause conditions such as meningitis and cavernous sinus thrombosis. Cavernous sinus thrombosis is a blood clot in the cavernous sinus, and this blood clot can then cause issues with cranial nerves 3 to 6, but not the mandibular branch of cranial nerve 5, as it doesn't run through the cavernous sinus. Mastoiditis is managed through surgical drainage of the infection, but you need to make sure that you're careful not to damage the facial nerve, which runs posterior to the ear. That's linked to another complication with middle ear infections, is that you can get paralysis of the facial nerve because it's such a thin sheet of bone between the middle ear and the course of the facial nerve. Another complication is something called a cholesteatoma, which is a collection of keratin, which releases lytic enzymes, which can damage the middle ear structures, obviously causing hearing loss. It also, if it's severe enough, can erode through the middle ear and start to damage structures surrounding the middle ear. So finally, obviously there might be a potential psychosocial impact. So with the recurrent middle ear infections that young children can get, you can lead to a hearing impairment. And at such a young age, this could have consequences for speech and language development. So consequences for learning would be that they might be unable to hear the teacher at school, which can also lead to behavioural problems because they just can't hear the teacher and can't pay attention. So you need to liaise with the school to make sure that the child is seated appropriately and so can hear the teacher and can learn properly. But yeah, that's us done. Any questions?